Imagine a mechanical failure that impacts nearly half of all women over 40.
Yeah, it's a massive number.
Right. And it dictates how you exercise, it alters how you laugh, and it basically mandates that you map out every bathroom in a 10-mile radius before you even leave the house.
Exactly. And it's something patients they adapt their entire lives around it.
They do. Yet standard medicine's best fix for decades has essentially been, do some Kegels or let's surgically implant a synthetic mesh.
Which comes with a, frankly, terrifying complication rate.
Right. So, welcome to today's deep dive. Today we are looking at a wildly different, pretty controversial alternative for stress urinary incontinence.
Or SUI, as it's known in the literature.
Exactly. We are taking a stack of clinical trials, urogynecology data, and the latest 2026 research to answer a really specific, highly searched question.
Which is whether a regenerative treatment, something often marketed under the flashy trademark of the O shot, can actually help stop you from leaking when you sneeze.
Yeah, is injecting your own blood really the answer to incontinence?
The tension here is definitely between that cosmetic branding and the actual biomechanical reality of what we're talking about.
Right, because if we strip away the silence and the stigma, SUI is strictly a mechanical failure under pressure.
It is. When you sneeze or cough or lift something heavy, there is this sudden, sharp spike in intra-abdominal pressure.
It acts like a massive downward force on the bladder.
Exactly. And the risk factors for this mechanical failure read like a standard timeline of a woman's life. Childbirth, aging, the hormonal shifts of menopause.
Or even just chronic coughing?
Right. They all degrade the structural integrity of the pelvic floor.
I was actually looking through the biomechanical models in the literature, and it really helps to visualize the urethral sphincter, not just as a simple muscle, but as like a high-tension hydrostatic valve.
That is a much more accurate framework, yeah. The urethra isn't just an open pipe.
Right.
It relies on the surrounding fascial tissue and that sphincter muscle to maintain a watertight seal. It requires resting tone and tensile strength.
Kind of like the knot on a water balloon.
That's a great analogy.
So when that tensile strength is compromised, the valve fails. You get that sudden spike in abdominal pressure from a sneeze, and because the suspension system is degraded, the hydrostatic valve it cannot maintain the seal.
The sneeze provides the pressure, and the degraded valve gives way.
The result is the leak.
Which brings us to the traditional landscape of how medicine has, historically tried to reinforce that failing valve.
Because before we can really appreciate why patients are actively seeking out autologous blood-based therapies, we have to look at the high stakes of standard treatments.
Right. If conservative options like pelvic floor muscle training or electromagnetic chair therapies, if those fail, patients are routinely pointed straight toward the operating room.
The surgical options.
Yeah.
So we're talking mid-urethral slings, colposuspensions, or injecting synthetic bulking agents.
And the goal of these procedures is to artificially recreate that mechanical backstop for the bladder.
But the clinical data from our sources highlights up to a 6% complication rate specifically for those mid-urethral slings.
Yeah, and 6% might sound small, but when you read the actual literature, that represents some incredibly grim outcomes.
Visceral injury.
Hemorrhage, voiding dysfunction, where the patient suddenly faces urinary retention and cannot void at all.
Oh, wow.
And chronic pelvic pain. But the most significant issue is actually the foreign body reaction to the synthetic mesh used in those slings.
Right, because your immune system identifies the synthetic material as an invader.
Exactly. If that mesh erodes or integrates poorly into the vaginal wall, it causes severe chronic pain, and it is notoriously difficult to fully explant or remove.
Knowing those risks, I completely understand the patient demand for a non-surgical alternative. But, I'm going to push back on the specific alternative we're exploring today.
The O shot.
Yeah. The branding sounds like a late-night cosmetic upsell.
Yeah.
It sounds like a wellness fad, not a rigorous medical intervention for a serious, hydrostatic valve failure.
Well, the skepticism is absolutely warranted because the marketing aggressively obscures the actual science. The trademark was originally branded to highlight improvements in sexual function. But if we bypass the commercial clinics and look strictly at the clinical literature, there's a different term.
The actual clinical term.
Right. The medical term for this investigational therapy is periurethral or vaginal platelet-rich plasma injection, or PRP.
PRP, okay. So we are talking about using a highly concentrated biological payload to force local tissue regeneration.
Exactly.
Let's break down that biological payload because we're talking about drawing a patient's own venous blood, usually around, what, 15 milliliters?
Yeah, a very small amount.
And running it through a specialized centrifugation process, like the Arthrex ACP double syringe system.
Right, which isolates the plasma layer that is densely packed with platelets at a concentration vastly higher than what normally circulates in your bloodstream.
So those concentrated platelets are basically the delivery mechanism.
They are. When they're introduced into damaged tissue, the alpha granules inside the platelets degranulate.
They break open.
Exactly, releasing superphysiologic amounts of bioactive proteins, cytokines, and growth factors.
And we are specifically looking at a cascade triggered by platelet-derived growth factor, or PDGF,
Transforming growth factor beta, TGF-beta.
and vascular endothelial growth factor, VEGF, which I know sounds like alphabet soup.
It does, but it's crucial.
Right. My reading of the cellular mechanics here is that this isn't just about, like, reducing inflammation. The superphysiologic concentration essentially forces local stem cells and fibroblasts out of senescence.
Yes. They wake up, the PDGF recruits the macrophages to clear out the degraded tissue.
And then the TGF-beta signals the fibroblasts to dramatically upregulate the production of collagen type 1 and 3.
Right, and you cannot build dense new structural collagen without a blood supply to meet the metabolic demand.
Which is where the VEGF comes in.
Exactly. It induces angiogenesis. It forces the creation of new capillary networks to oxygenate the area. You are triggering a localized, hyperaccelerated healing response.
Okay, so we have the construction crew and the materials. But if we take this concentrated biological payload into the clinic, how does the actual application translate to fixing a leaky hydrostatic valve?
The procedure itself involves applying a topical 2% lidocaine cream for numbing.
Right.
And then a clinician injects 5 to 6 milliliters of this PRP directly into the anterior vaginal wall, the clitoral area, and critically, right into the submucosal plane of the urethral sphincter.
By injecting directly into the submucosal plane, the PRP is positioned exactly where the structural integrity has failed.
Exactly where the valve is weak, the cascade you just described goes to work. The tissue between the vagina and the urethra actively thickens as new collagen is deposited.
But it goes beyond just structural scaffolding, doesn't it?
It does. The growth factors promote myogenesis, which is the actual repair and proliferation of muscle fibers in the sphincter.
And neurogenesis, right? Restoring degraded nerve signaling to the area.
Yes, it's actively instructing the tissue to reverse its own degradation.
That's wild. And the sources provide urodynamic proof of this. We aren't just relying on subjective patient surveys saying, I feel better.
No, clinicians actually measure the abdominal leak point pressure.
Which is the exact physical threshold of intra-abdominal pressure required to force urine past the sphincter.
Right, how hard you have to push before it leaks. And post-PRP, that pressure threshold significantly increases.
The biomechanics of the valve literally improve.
The sphincter regains enough resting tone and tensile strength to withstand the sudden pressure spike of a sneeze without giving way.
But, theoretical biomechanics and actual clinical efficacy are two different things.
Oh, absolutely. A lot of procedures make sense on paper, but completely fail in widespread human trials.
Right. But when we look at the aggregation of recent data, specifically the 2026 meta-analysis published in Frontiers in Medicine, we finally have some real statistical power to evaluate this.
Yeah, that's a massive study. We are looking at a review that pulled together 8 different studies encompassing 257 patients.
A meta-analysis of that scale is vital for isolating the true efficacy of PRP from, placebo effects or just spontaneous remission.
Definitely. And the aggregated data from those 257 patients demonstrated significant short-term improvements in symptom severity.
They tracked standard, validated urological questionnaires, right? Like the Urogenital Distress Inventory.
And the Incontinence Impact Questionnaire. The pooled data showed substantial reductions in negative scores at the 1 to 3 month mark.
There's another really compelling piece of data from a prospective pilot study out of Government Doon Medical College in Derridon.
Yeah, they took a very measured approach with 15 women administering 2 periurethral PRP injections spaced 6 weeks apart.
And they didn't just use questionnaires. They tracked 3-day bladder diaries to quantify the exact frequency of daily leakage events and pad usage.
Plus, they utilized objective cough stress tests over a 6-month follow-up.
And the findings there perfectly mirrored the broader meta-analysis.
They did. The bladder diaries showed a quantifiable drop in leakage episodes.
And the physical cough stress tests confirmed the objective improvement in the valve's integrity. It directly answers our core question. The clinical data confirms that perurethral PRP can indeed stop the leaking when you cough or sneeze.
It really can.
But I do want to pause here and inject a serious reality check.
Please do.
Because the internet ecosystem surrounding regenerative medicine tends to flatten nuance into this miracle cure territory.
Oh, constantly.
We have to clearly bound the efficacy based on these sources. PRP is highly promising, yes, but it is indicated for mild to moderate stress incontinence.
That distinction is paramount. If a patient is dealing with severe SUI, meaning the fascial support is entirely gone and the hydrostatic valve has completely failed mechanically, PRP simply may not provide enough regenerative scaffolding to bridge that gap.
Right. It cannot replace a totally destroyed pelvic floor.
Exactly.
And we also have to distinguish the trigger. We are talking about a mechanical failure under pressure that is completely different from urge incontinence.
Which I see conflated constantly in the wellness space.
Same, but conflating the two leads to massive treatment failures, right?
Absolutely. Urge incontinence is not a failure of the sphincter's tensile strength. It is a neurological and muscular issue where the detrusor muscle of the bladder spasms aggressively.
It creates an overwhelming, sudden need to void, regardless of how full the bladder is or what pressure the sphincter can hold.
Right. So if you sneeze and leak, that is a structural failure. That's SUI.
But if you're sitting perfectly still, feel a sudden spasm, and can't make it to the bathroom, that's urge incontinence.
Exactly. And PRP does not target the detrusor muscle spasms of urge incontinence. For that, the urological literature points to entirely different pathways.
Like intravesical Botox injections to paralyze the spasming muscle.
Or sacral neuromodulation devices to override the faulty nerve signals.
So patients really must insist on a differential diagnosis before seeking PRP.
They have to. And beyond the diagnosis, there needs to be a real alignment of expectations regarding the timeline. Regenerative medicine operates on biological time, not surgical time.
Right. If a surgeon implants a mesh sling, the mechanical backstop is there the exact moment you wake up from anesthesia.
But with PRP, you are initiating a cellular cascade. You won't walk out of the clinic and immediately be able to jump on a trampoline.
The biological payload takes time to act.
It does. The fibroblasts require roughly 2 to 4 weeks to meaningfully engage the cellular remodeling and collagen deposition process.
So patients typically don't see the peak urodynamic results until, 3 to 4 months post-injection?
Exactly. It requires patience.
Which naturally leads us to the reality of the patient experience in the clinic. Considering it works best for mild to moderate cases and takes months to peak, what is the actual risk profile?
Because the safety data here is arguably the most disruptive aspect of PRP therapy when compared to traditional surgery.
The safety profile is entirely driven by the autologous nature of the treatment, right? Autologous meaning from your own body.
Yes. Because the material is synthesized entirely from your own venous blood, the risk of a severe allergic reaction, tissue rejection, or those catastrophic foreign body responses seen with synthetic mesh, they are virtually eliminated.
The 2026 meta-analysis actually noted that across all the aggregated studies, the procedure was highly tolerable with 0 major adverse events reported.
0. The side effects are localized and transient.
Mostly just mild swelling, perhaps some spotting at the injection site, which resolves within 48 hours.
And the recovery time is minimal. Patients are resuming their normal daily activities the exact same day.
With the only real clinical restriction being the avoidance of sexual activity for 24 to 48 hours.
Right. However, we do have to contextualize the longevity of those results.
Because a synthetic surgical sling is a permanent physical implant designed to be there for life.
Exactly. While the regenerative effects of PRP are profound, they are subject to the continued realities of human biology.
Right. Biological aging doesn't just pause because you optimized your collagen.
Sadly, no. Gravity, hormonal shifts, and the natural wear and tear of the pelvic floor continue.
So the consensus in the literature is that the reinforced tissue integrity from a PRP treatment lasts anywhere from 9 to 12 months, with some patients maybe stretching out to 24 months.
It really is a chronic management strategy.
To maintain that increased abdominal leak point pressure and stay continent, patients must anticipate the need for maintenance injections every year or two as the tissue naturally degrades again.
Exactly.
Let's zoom out and pull these threads together. Stress urinary incontinence, the isolating reality of leaking urine when you sneeze, laugh, or exercise, is fundamentally a failure of a biological hydrostatic valve.
A mechanical issue.
Right. For a long time, if conservative therapies like Kegel's didn't work, the medical establishment offered a highly invasive choice. You endure the leaking, or you risk the severe complications of synthetic surgical mesh.
But now, by leveraging systems like the Arthrex centrifuge to isolate the growth factors in just 15 milliliters of our own blood, we have a minimally invasive alternative.
By injecting PRP directly into the submucosal plane of the urethral sphincter, we can force the local tissue to regenerate muscle and nerve fibers.
Safely restoring the structural integrity of the valve for mild to moderate cases.
The ultimate takeaway for you, the listener, is the massive shift in power this represents. Intimate health issues like incontinence carry such a heavy burden of silent embarrassment.
They really do, leading millions to quietly accept a diminished quality of life.
But by understanding the specific biomechanics of your pelvic floor and recognizing that autologous regenerative therapies now exist in the clinical literature, you have the data to seek help.
You can explore targeted tissue regeneration before ever allowing a surgeon to introduce a synthetic implant into your body.
And I want to leave you with a final lingering thought to mull over. We've just spent this deep dive exploring how we can extract our own blood, concentrate its supraphysiologic growth factors, and re-inject it to literally rebuild a failing hydrostatic valve in the pelvic floor.
It works for joints, it works for hair follicles, and the 2026 data shows it works for the urethral sphincter.
So the provocative question is this. As we map the precise signaling mechanisms of these biological payloads, what other degraded aging suspension systems in the human body might we eventually be able to repair simply by forcing our local cells to act young again?
It's a fascinating prospect.
If we can teach a failing valve to hold tight, using nothing but our own biology, the future of medicine might not be about what materials we can invent to implant into the body, but what dormant regenerative codes we can unlock from within it.